So far we have a few questions. I was going to take Chair's prerogative and ask a couple off the top. I guess kind of, Fred, building on sort of my question yesterday for Dr. Teitelbaum, I think having patient-centered care is terrific, but from a system standpoint and a discipline standpoint and sort of to improve the state of our patient care, how can we measure how well we're doing with patient-centered care? Because if you can't measure it, it doesn't matter.
So I think you have to distinguish between providing the basics of dialysis care, and a lot of that has been defined. Hemo should be done 3 times a week, targeting a K/V of 1.2. The PD target is not as clear as discussed yesterday. Using a PD target of 1.7, for example, is a way of deciding how much dialysis perhaps should be prescribed. But then what's crucial is the outcome measure which is followed is not simply the K/V, but how the patient is responding to that. So the example that Isaac gave yesterday was a good one. If someone's got a K/V of 1.6 and they're feeling perfectly well and they're on 3 exchanges a day, does the prescription need to be changed simply to satisfy a CMS requirement, or can it be individualized for the patient? And I would suggest the latter is the way one would approach that. So I think you need certain basic standards of care. Hemoglobins need to be in a certain target as part of the care. But what level that should be at can be individualized once you've achieved that.
How about, I guess, can I, just so that I understand that, I guess, if I understand you right, you're okay with certain standards, like having a certain KT/V or a certain hemoglobin, with the notion that it can be individualized, right? And yes. I guess where I see the challenge is when you're looking at sort of the data of a provider or of a health system, if everything is allowed to be individualized, then you have no standard.
I guess the question would be, should the final standard of care be how many people are at a K/V of a certain, whatever number you decide it should be, or it should be, are they satisfying meeting individual patients' goals? So shift the focus to be, what are the goals of the patient? Is it comfort? Is it longevity, for example? Is it level of physical functioning? And are those goals really being met? That would be a shift, I think, that could be achieved.
I'd like to add to that just real quick. I mean, I don't have a great answer for it, but I just want to talk about it. We do not have a good, robust measure of physical activity. I think, to me, even more so than measuring physical function, but depending on what an individual patient, from an exercise perspective, whatever intervention they do, if you're trying to measure physical function by a walking test or a strength, hand grips, it's going to differ depending on what they want to do. So the metric that I've sort of come upon that I really want to focus on is just time spent in physical activity. And now that's something that's going to excite a lot of people, but for the patient, if we know that patients are moving or are doing volitional activity 5 minutes a day or 0, right, and we can get them where they're moving 30 to 40 minutes a day or something like that, that's you're going to be producing benefits on some of that are very difficult to capture, and it doesn't make for a great randomized clinical control, a primary outcome, but that's, in terms of improving the patient's health and quality of life, if we get them moving more, there's a lot of evidence that it's going to have many benefits that are just difficult to capture. So that's the one we're really focused on.
Great. I guess to Dr. Chertow, to me, it was really terrific to kind of have, the history of dialysis trials over the past 40 years outlined. I guess what I was sort of missing was where's the really high-risk, innovative interventions within nephrology? I guess, and part of this is the type of trials you were describing were the large multi-center trials, but to go to oncology as an example, where's our checkpoint inhibitor trials? Where's the things that are high risk and potentially groundbreaking? Where is that going to happen?
Well, I think when many of us probably attended ASN, and I think this year there was a palpable increase in the number of at least new drug agent trials, not in ESRD, but in CKD, in different forms of CKD. I think the emerging data on SGLT2 inhibitors is extremely exciting. And there are many agents currently under testing. I think in terms of the dialysis trials, we're still doing dozens and dozens of things, based on myth and shibboleth. And I think we could test them. And I'm not sure that we need to test them in 40,000 patients looking for, a body count at the end of the day. I think we can test them looking for things that Fred and I and you and all of us really care about, like how the patient feels. And I'm a little bit suspect about some of the surveys that are given to patients that say that they don't place living longer very high on their list of objectives. If they feel like crap, they don't really care about living longer. Right. And if they feel better, then they really care about living longer. And so I think we need to work in parallel to figure out ways to help them live longer, but feel a lot better along the way.
Dr. Wilund, so to me it was interesting that your focus is on sort of activity and movement now, and in addition perhaps to some in-center activity. What, just in terms of your thinking, and for those of us that have integrated EMRs, what role can mobile health play in this and making sure that patients are adhering to a prescription of exercise?
It's not something I've particularly done a lot of work in, but there's a lot of others that are starting to look at this, and some of the data looks pretty interesting. The patients in the clinics I've worked in, which is a lot of inner city Chicago, it's been difficult to try to get in touch with them on any level, whether it's using a smartphone app or emailing. There's anything we've done trying to do remotely with them has not, we've struggled with. So I think there is a lot of potential for it, but we're not there, and some others in some other countries have done. I think they're moving in that direction to make some progress.
Dr. Finkelstein, how do we get away from the stigma that self-reported measures of patient-reported outcomes are viewed as a limitation of a particular trial? I think this sort of, to me, I hear this a lot, that it's objective and soft as an outcome. As the PRO man, what do you say to that?
If patients report themselves not feeling well, they don't feel well. That's the bottom line. You can say, how is that a soft outcome? I mean, if they don't feel well, they don't feel well. Right. They'll give you, and that can be measured from a variety of other ways, but if they say they don't feel well, then they don't feel well. That's it. I'm not sure what else you need to document.
Can I add to that?
Yeah, sure, please.
I guess when I'm faced with that critique, we do a lot of things where we have to measure something, and I guess for many of the PROs, their measurement properties are as good as many of the sort of clinical measures that we do, right? Right. Like blood pressure or PFTs or whatever.
For sure. That's a good question.
For that matter, hospitalization for heart failure or other things. But I think there are patient-reported outcomes that can be used in certain settings that are less prone to bias than others. So I particularly like the sit-to-stand test, because it not only highlights physical capacity, it also has direct relevance on patient safety in the home. If a patient can't get up from a chair, he or she is likely to fall down the stairs and is going to need more assistance and some physical strengthening, some more intensive physical therapy. So I think looking at performance tests as well as self-reported, patient-reported outcomes, I mean, they can be patient-centered outcomes and not necessarily patient-reported.
I guess when you do the sit-to-stand test, do you use these sort of lounge chairs? Because they're really hard to get out of.
You need a crane. I need a crane to get out of those chairs.
So Ken, could you speak to that a little bit? I guess there is a perception by some that, these sort of more quantitative measures really add to patient-reported outcomes. What do you think?
Well, the problem that you're highlighting it by talking about these chairs is the way the tests are normally done, they're not done very well. And when you're introducing variability into a test often that you're not going to see really robust functional improvements based on a lot of interventions. And when you introduce variability by performing the test incorrectly, it's going to dilute the effect. So I love sit-stand. I mean, when it's done correctly, it's a really good test. It's exactly for the reasons you're talking about. But you've got to have a standardized script. And that's one of the things we're trying to do is develop standardized scripts and some training for that, so that the test can be done properly to capture the benefit. And it's probably my favorite outcome, honestly. I think for the reasons you said.
If I could just ask one quick question.
Please.
Ken, you went through randomized trials showing that exercise is not of benefits. This is a question for you and Glenn. But yet you're convinced that exercise is a good thing and you're pushing forward doing it. So here's an example where randomized trials show no benefit, but yet on an individual basis you feel this should really be pushed forward. So maybe you and Glenn can comment on that, how you interpret that.
Yeah, go ahead.
Personally, I would say that there's very little risk. So whenever we're evaluating results of an intervention, we have to balance the benefits and risks. And so an intervention that has very low risk, even if the evidence is so-so, you're probably willing to forge forward because there's very little risk, as opposed to, for instance, the example, not to get back into the debate mode, but the example of ESAs. I think a doubling of the stroke risk and a 5% risk of stroke over 2 years is a sizable risk. And so I certainly agree, and I'm sure that in our discussions with patients and in yours that you are sharing those risks with the patient as he or she makes the decision. But I think exercise has there's so much evidence from observational data, and the risk is so minimal. As long as it's done, I don't have my 90-year-olds on treadmills, but I think the risk is so minimal that I would proceed even in the absence of unbiased evidence. And remember, the absence of evidence isn't evidence of absence. And so sometimes there's so much variability. As Ken said, there's so much variability in the studies that you sometimes just don't show a significant effect when there is one.
Yeah, I can't add much to that. Just reiterate a couple points here that, it's because of the variability, you're just not able to capture for any particular intervention, type of exercise intervention. If you have a lot of internal validity and you do everything the same for every patient, then it's not practical. Most people don't exercise like that. So you've got to accept the observational data, not just from CKD, but from the rest of the world, that it does work. And really, the focus, I think, needs to shift to the exercise literature, figuring out, it's about behavior change and getting more patients to move more and focusing on interventions that can address that as opposed to a robust outcome that is going to make the world happy.
So one could say the same is true in randomized trials where patients of varying backgrounds and comorbidities are pooled, and then one tries to separate them out with statistical analysis, but you often can't do that. So the truth is, in the ESA trials, the percentage of people who really have significant responses is a bit higher. And to go back to the Yale professor, he did not have a viral infection, and he really did have a response to the treatment with the ESAs and was willing to accept the risk. So to say that you should be prohibited, in essence, from driving those hemoglobin levels up is really not appropriate, and that's why sort of the CMS standards with the penalties is really a problem. Okay, fine.
So, Dr. Finkelstein, to me it was sort of interesting that you highlighted kind of the approach of a cancer center in providing personalized medicine. In my experience with comprehensive cancer centers, every single patient is on a protocol. And in nephrology, it's very different. I mean, the protocol may be individualized to that patient, But nonetheless, every single patient practically is being studied. How does that sort of, like, could you imagine an approach to nephrology where we enrolled every single patient into a trial?
Well, I think that the difference in the oncology studies is that in nephrology, we're just taking all comers and pooling them in a study, taking all diabetics with cardiovascular disease and putting them in the TREAT trial as an example. In oncology, the patients are being stratified based on sort of more individualized testing, and therefore the experiences are in fact unique. And then what the BASH paper discusses, the one in the New England Journal, is that the therapies carry a lot of risks with them and they carry morbidities with them, but it's important to track those, and based on that you can adjust your treatment. So in that sense they are individualized, and that's what they've done in oncology, and that's what we've not done in nephrology.
Glenn or Ken, do you?
You know, I don't want to, I didn't want to be too negative about the time trial. I think the time trial is a good example of where patients on dialysis could participate in clinical trials, and an entire cluster of dialysis units could receive one intervention and another cluster could receive another intervention, and some of the crazy things that the nurses do, like slowly dialing up the blood flow or whatever else they mannitol, other things that they might use that are part of standard practice could actually be tested. So I think it's actually doable in the dialysis world. It's easier in many ways in the dialysis world to test some of the interventions, to test some of the things that we do that are part of variable standard care, and I'd love to see that. As far as CKD goes, I'd like to see that as well. I don't see why we shouldn't move toward that. Kidney disease is, as you know, it's the 9th leading cause of death in the U.S., so it's not quite up there with cancer, but it's still a major problem. Half of all Medicare expenditures are spent on patients who carry a diagnosis of CKD. It's a big deal.
And then I guess just to kind of expand on that and to address one of the questions is, like, so in your mind, the sort of value of a pragmatic trial versus kind of the classic randomized trial is that we could, nothing is easy, but one can imagine sort of systematically addressing kind of all of the things that we do based on very little or no evidence in dialysis, versus sort of a more classic randomized trial like hemo, where there's a lot of infrastructure that needs to be put into place?
Well, a cluster randomized trial would not be suitable for a complex, say a drug intervention, right, where certain patients would be excluded based on concerns about specific risks. But for evaluation of practices that are not evidence-based, but that are widespread, I think they're ideal. And kidney disease in general is full, I think for reasons that Fred and I both highlighted, it's full of practices that have not been based in evidence.
But just to go back, a problem like you could argue with the time trial is simply doing a pragmatic trial, clustered trial, where you incorporate all patients in different facilities into the trial is not the right way to do this. For example, you could stratify patients on post-dialysis time by those who have post-dialysis fatigue, those who get dialysis-related hypotension, in which case you might be able to preserve that difference rather than just taking all comers. And that's the difference in oncology and nephrology as I look at it when you look at the randomized trials. Is that not right, or am I wrong, Glenn?
I don't disagree with that.
Yeah, okay.
That's just practically, in order to get enough people enrolled in a trial like that, that approach would be terrific. It would be much more difficult.
Yeah.
So can you, we talked a little bit about the benefit or modest benefit of exercise during dialysis. Could you talk a little bit about the serious adverse events and other adverse events that you've seen as a part of dialysis trials?
Yeah, they're virtually absent.
Okay.
And I'm glad you brought it up, though, because in a lot of trials, we've had so many exclusions, and there's based on, the exclusions they could come from the investigator, they could come from, nephrologist or the IRB board mandated or whatnot, but there's the problems associated with exercise, the risk, are dwarfed by the benefits of getting people moving more. There's almost no evidence in the literature of adverse reactions to exercise or people dying while cycling or anything else. It just isn't there. Get them moving more, and I'll go one step farther. One thing that happens, there's a movement to get. I've heard others talk about the need for doing exercise stress testing before admitting patients into trials. I think that's ludicrous because it's just another barrier to getting our patients moving more. We're scaring everybody out of moving more. We know it's beneficial, and there's reasons for it. I get it, but the data doesn't support doing things like that.
And then could you speak to the impact of exercise on the type of outcomes that Dr. Finkelstein cares about? Like, the patient-reported outcomes, the sort of self-reported quality of life?
Yeah, the self-reported quality of life has been up and down in different studies. Sometimes you see benefits, sometimes it's very inconsistent. We're getting more data now. People are looking at specific things like patient-reported outcomes, whether it's restless legs or sleep, and all the studies are small. It's really difficult to say that exercise trials have benefited these things. Again, anecdotally it works, but we don't have robust trials to demonstrate that, but we've certainly have the anecdotes from patients, and I know anecdotes aren't always data, but I see it with my own eyes, and I do believe it. It's just not captured in the trials very well.
Dr. Chertow, I think this next question is sort of addressing kind of how we interpret the nocturnal FHN trial, in that, how much of the lack of a positive outcome, again, maybe you could reframe this for us, in the home dialysis patients was due to sample size, and how much basically was a consequence of the change or loss of residual renal function, and then can we extrapolate that to a population that doesn't have residual renal function?
Right. So I think the questions are very well informed. And again, I would just point out that a failed trial doesn't mean that we should castigate the investigators or be negative in any way. Clinical trials are difficult, and some of the problems that we encounter with them are not, they're not anticipated, and they do come up. So I think the biggest problem with the FHN nocturnal trial was that recruitment was so difficult that the investigators ultimately basically relaxed the inclusion criteria for the study, including allowing people who were incident to dialysis to enter the trial, and those patients had probably too much residual kidney function to benefit as much as they might otherwise have. Now, John Dalgirdis, who's here, I've been picking on him a little bit, but he authored several key papers related related to FHN that highlighted that there was a relationship between the degree to which patients would benefit from a number of these intermediate outcomes and their residual kidney function. So we know that having 4 or 5 or 6 ml of residual kidney function is better than anything we can do with a dialysis machine. And so including those patients in the trial almost certainly diluted the effect. And then, of course, the sample size was small, but the relaxation of the inclusion criterion, I think, was the biggest reason.
I'd like to close with one quick question for the group. It's really sort of, there are some common themes that have been talked about, like, including outcomes that matter for patients, the need for more data. To what extent can we inform the clinical trials that we are designing by including the key stakeholders up front when we're designing this study? The key stakeholders would be the dialysis organizations and patients and patient advocates. To what extent can that inform, like, the trials that we do? Ken?
I'll start. Yeah, so that's one of the things we're really focused on in the GREX group, the network. We've got patient partners involved in this, and we've learned a ton. We had our first sort of big meeting in Calgary last November, and we invited a lot. And the patients that we had a session just from the patients talking to us about what they thought of when they thought about exercise, and it really opened our mind in terms of what they consider, how difficult it is for them to exercise, and what they consider exercise. And the thing that I took away from it is that they, all they really want to do is figure out ways to do what they're currently doing, do those better. They don't, again, they don't care about the outcomes that we care about. They want to take whatever they're doing, whether it's cleaning their house, and be able to do that better. And how do you capture that? But we don't know. Going in, we haven't addressed that at all in the past, and we've got to take their voice into account to design better trials.
And then quickly, Dr.
It's
Finkelstein.
an important point, and with Isaac, when he discussed the new high-quality PD guidelines, patients were involved in those discussions, and there were patients from nearly all around the world, but a very limited number of patients. A challenge is how you include patients when they come from multiple and diverse ethnic, cultural, and medical backgrounds, and that's a challenge. So I think patients need to be incorporated, but how to do that is very challenging and difficult.
Dr. Chertow, last words?
Just last words, I think Ken pointed this out earlier. Standardizing the measures will make a real difference. So we're never going to be able to capture what each individual trial participant or other cohort study participant wants in terms of cleaning his home or whatever. But if we, like some of the cognitive tests that Dr. McIntyre showed earlier, developing norms and developing standardized, validated instruments for us to use. This is, I know, something that Song is working on from patient-reported endpoints, but I think the more of these measures that we can validate and use in our population, the better. Whether sit to stand or the cognitive tests or whatever else.
So I guess to conclude, I think that all of our speakers would agree that we kind of need more data that's important to our patients, and that there's opportunity in nephrology for increased clinical trials that are individualized to patient outcomes. And I want to thank the speakers for a very civil discussion. Thank you.